Welcome everyone to today's webinar, Proving the Clinical and Financial Value of Single Sign-On. I am Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will be sending all registrants a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter, Dr. George Gellert. Dr. Gellert is a physician executive and epidemiologist focused on health information technologies with a track record of formulating and executing innovative, transformative organizational strategy. Dr. Gellert formerly served as the Associate Chief Medical Information Officer, or CMIO, for Christus Health, an integrated delivery network with 49 hospitals and long-term care facilities and 175 clinics and outpatient centers in 6 states, Mexico, Chile, and Colombia. He was responsible for ensuring superior performance and optimization of clinical information technology and effective health informatics operational support of over 15,000 Christus physicians and 6,000 nurses. Dr. Gellert has served in industry like GlaxoSmithKline, WebMD, NGOs, and in the nonprofit sector, as well as in government and at the United Nations International Atomic Energy Agency. He is a graduate of McGill, Yale, UCLA, and Harvard University. He is a fellow of the American Board of Preventive Medicine. Dr. Gellert has published over 140 articles and letters in the peer-reviewed medical literature, book reviews, and chapters, and presented at over 220 scientific meetings and conferences. At this time, I'm pleased to turn the floor over to Dr. George Gellert to begin today's presentation.
Thank you. Hello, everyone. I'm delighted that you could join us for this webinar. I'll be talking about the evaluation of single sign-on in the Christus Hospital system, an analysis that we completed several times over the last several years. Next slide, please. Before jumping into that, I just want to mention my co-authors and collaborators in completing this work. This was done while I served at Christus Health for 6 years, from 2011 to 2017. In addition, John Crouch, a director of information management at Christus Health, was a close collaborator and co-author on this work, as was Christus Health's Chief Technology Officer, Lynn Gibson, and its CIO, George Conklin. Next slide, please. The work I'm about to show you will appear in AHIMA's official journal, Perspectives in Health Information Management, in the upcoming summer issue. So you'll be able to not only get this information from the posting of these slides online, but in about a month or two, you'll have it available online with the full article. In terms of background, we all know that meaningful use brought us the era of EHR adoption, and with it, of course, the need to protect health information and ensure that we are complying with HIPAA requirements. The challenge, of course, with the typical sign-in and passwords is that what makes them really effective, that is, being complex and changing them often, also makes them difficult for folks to remember. And in particular, as you can imagine, busy clinicians have many things they're trying to keep on top of mind, and frequently they're in need of password resetting due to forgetting passwords and so forth. We've seen in the literature and in our own experience that clinicians must often recall and refresh anywhere from 8 to 20 or more passwords for the various software programs they use in providing care to patients. Next slide, please. So clearly, time is lost by clinicians when they are having to reset passwords. This is something that competes for their finite time. The concept really underlying single sign-on as a product is to facilitate clinicians' use of the EHR, including the CPOE and digital documentation modules, by providing clinicians with expedited access to the EHR and the applications that they use. Single sign-on seeks to eliminate password confusion and the time wasted in password management. In addition, effectively implemented, SSO will increase or enhance HIPAA compliance by adding another layer of authentication. Next slide, please. With single sign-on, once a clinician logs in for the first time of day through the usual manner with a password and a user ID, for the balance of their shift, they need only swipe or tap an enabled identification proximity badge on a workstation card reader. Across the hospital, this kind of tap and go enables clinicians to pick up exactly where they last left off in the EHR. And it expedites their access to the EHR and any other functionality they may be using as they change location or meander through the hospital. When the clinician changes their workstation, a tap on the badge reader will bring up the most recent screen that they were working on. Next slide, please. Single sign-on will automatically lock the workstation when care providers leave that workstation, and it re-authenticates them when they return to where they left off. This eliminates the need to manually lock sessions or use what are sometimes unreliable inactivity timers, and it prevents loss of work, which of course, as you know, is a major problem that clinicians can encounter having entered fields of data into the EHR and being auto-logged off. They could lose that. So single sign-on reduces repetitive manual logins through an automated process. Next slide, please. SSO will expedite authenticated access to all of the clinicians' applications during a 12-hour shift, after which they need to log in again in the usual manner. And they will then get another 12 hours of tap and go, as it's informally called by the clinicians themselves. SSO provides support for all types of applications, including terminal, client-server, and cloud-based apps. Password administration enables automated application of password changes and eliminates this task entirely for clinicians. Next slide, please. So when I was working with Chris's Health, the team and I wanted to try and see if we could evaluate the impact and the value of single sign-on. We were impressed with the volume and quality of the data that our particular product, which was Imprivata OneSign version 5.1, we were impressed with the information, data that Imprivata's OneSign would provide us. We wanted to see if we could utilize one or more of the data reports we had access to evaluate how much time was actually being saved by our clinicians. So this is really a study, a quantitative evaluation of single sign-on impact in 19 Christus Health hospitals where OneSign was implemented. Christus Health, as was mentioned, is a mid-sized IDN present with markets in 6 states, has over 350 services, 49 hospitals, and about 15,000 physicians affiliated with the system. The EHR in these 19 hospitals was Meditech Client Server version 5.66. As I mentioned, the SSO product we use was Imprivata's OneSign version 5.1. We were able to get reports from OneSign on a number of different variables around clinician single sign-on use, including the number of deployed users, the number of active users, the number of logins, the frequency of access to differing applications, the average logins per user, and the average application events per user. Next slide, please. In our instance, the implementation of single sign-on required migration from workstation PCs to a thin client and cloud processing. We really needed to migrate to a virtual desktop infrastructure, or VDI, to enable this kind of clinician roaming across different service lines. Our PC-based prior implementation really didn't work well with SSO. We had, in a pilot project, considerable problems, and frankly, it was good we did a pilot, because it was through that pilot that we discovered that we really needed to advance part of our basic infrastructure in order to enable SSO to operate effectively. If you think about what SSO does, it really is a rather complex technology. It sounds simple, one login and tap and go to access all these different clinical applications, but ensuring that each clinician gets access to the particular software applications they need to consistently, reliably, and without failure is actually a complex technical undertaking, both in terms of the product, SSO product, but in terms of your implementation. We wanted to have 45 different clinical software applications profiled and enabled on single sign-on. Our strategy was initially to provide SSO just to physicians and nurses, as well as mid-levels. But frankly, as soon as the ancillary team members saw the ease of access that was now enabled for the rest of the clinical team, they made a passionate plea for us to include them in it, and so we rolled forward with the implementation, including ancillaries as listed here: respiratory therapists, physical therapists, and dietitians. Next slide, please. We studied a 7-day observation period of the usage of single sign-on in April 2018. We measured the mean login duration to the workstations both before we implemented single sign-on and then compared it to a 1-week period after we implemented single sign-on. After single sign-on was implemented, the usual login process now broke down into 2 components, as I mentioned earlier. The first login of the day to the desktop was using a traditional system user ID and password. But all subsequent connects to the EHR and other clinical applications, what we refer here in this presentation to as re-logins, use the card reader technology. We multiplied the mean login durations by the total number of initial and subsequent logins to get the full duration of login time. Next slide, please. In this manner, we assess the total time required for clinicians to log in both before and after the implementation of single sign-in. And we were able to quantify the benefit achieved from decreasing the amount of time clinicians were spending logging in, what I call time liberated from keyboard. Then we had to figure out what the value of these different clinicians' time was, because we felt that while it would be of value to demonstrate the total time saved, it would be even more compelling in terms of rationalizing our investment in single sign-on to show what the actual dollar value was of the different clinicians' times we were saving from keyboard, according to what those differing members of the clinical multidisciplinary team were typically paid. So we used national median hourly pay rates to translate the hourly and shift time savings into actual dollar cost value of the clinician time liberated for keyboard for these 3 clinical groups: physicians, nurses, and the ancillaries. We estimated cost savings of replacing our PC hard drives with a thin client that created access to our cloud functionality. We also sought to calculate, because we knew that we were paying about $900 per unit for replacement PCs, and the thin client or WISE devices that we were using were a fraction of the cost. Next slide, please. Now I'm going to show you the results. Next slide, please. So this table summarizes the major parameters of the study. We had about 12,900 active clinical users of single sign-on across these 19 hospitals. And the total number of logins to the EHR over a 7-day period were about 184,000. Of that, the first of shift logins were about 24,000, and the subsequent reconnects or re-logins over the balance of that 12-hour shift over the course of the 7 days we observed was about 160,000. Next slide, please. This summarizes our measurement of the actual mean login duration across the different hospitals, where we actually had members of our information management team go out and log in during the observation period or weeks, and actually time how long it took to log in till they had access to the EHR. And then we averaged those out. Pre or before SSO implementation, the first of shift login time was 34.6 seconds. After we implemented SSO, that dropped marginally really to 29.3 seconds. Where we saw the really big impact, however, was in the reconnect time during the rest of that clinical shift. Before SSO implementation, on average, the reconnect time was 29.3 seconds. This fell dramatically to 8.9 seconds after the implementation of SSO. So in the first login, we saw a rather marginal decrease, but still substantial at 15.3% reduction of login time. But dramatically for the relogin, we saw almost a 70% reduction in time for relogin after we implemented single sign-on. Next slide, please. This slide tries to convey the total amount of time, or what we call keyboard time reduction, during different phases of the study, comparing before and after implementation. So the time duration for the first of shift logins during our observed week before single sign-on, it was, when you added it up across all the providers who were utilizing single sign-on during our observation week, that equaled 235 hours. That's roughly equal to 19 12-hour shifts. I use the term throughout the balance of the presentation and slides of shift equivalents. I'll just shorten that to shifts, but always referring to a 12-hour shift. Again, the idea being to try to make the hourly figure translate into something we're all more familiar with, and particularly hospital, clinical, and administrative leaders can appreciate what that really means. So the keyboard reduction post single sign-on fell for the first of shift logins to 199 hours, or about 16 shifts. In the lower half of this table, you see the login duration summarized for the reconnect over that 7-day period. And here again is where we see the really dramatic impact. Pre-SSO implementation, that required about 1,300 hours, equivalent to about 108 12-hour shifts. After SSO, that dropped to 395 hours, or about 33 shifts. So that's a net reduction in re-login time of 907 hours, or about 75 12-hour shifts. Next slide, please. When you summarize the numbers in the prior table, looking at over an entire week across 19 hospitals and then a single hospital as an average, you see the data in this table. So over the enterprise, the weekly time savings enabled by single sign-on across the 19 hospitals is about 943 hours, just shy of 79 shifts. For a single hospital, on average, that would be just shy of 50 hours, or 4 shifts. We then translate that into an annual time savings in the lower half of this slide. For 19 hospitals on an annual basis, we're liberating from keyboard over 49,000 hours of clinician time, equivalent to almost 4,100 shifts. At a single hospital level, that would be about 2,584 hours, or 215 shifts on a calendar year. Next slide, please. So next we wanted to translate these time-saving numbers, as I mentioned, into some sort of dollar value. And that required us trying to quantify from existing evidence or data available on the web from various sources what the average value was based on an hourly wage rate of the different clinicians who we had enabled to use single sign-on. So we did this across the three categories of physicians, nurses, and ancillary personnel. In our particular observation period, and we think this translates more typically beyond the observation period as a standard over ongoing use, 30% of our clinical SSO users were physicians, 57% were nurses, and 13% were members of the ancillary team. For determining nurses' hourly wage, we used a national average wage that's reported in various sources as $34.50 per hour. We had some variations, as you might expect, across the different categories of ancillary team members, but we averaged those out. We averaged the averages for each of these three categories and came up with a single average for the ancillary category as a whole of $32.20 per hour. Next slide, please. Estimating physicians' hourly wages was considerably more complex because there's considerable income variation in hourly wage rate across differing specialties. We decided the best way to approach this was to divide our physicians into four groups of the highest EHR users, anticipating as a reasonable assumption that the highest EHR users were also using SSO to the greatest extent because they had to log into the EHR to be a high utilizer of it. And so these four groups were in descending order of volume of use of the EHR as measured by order issuance in CPOE: hospitalists, emergency medicine physicians, general surgeons, and then all other physician categories, including consultants, collapsed. We estimated that each group used the EHR and its applications roughly 25%, equal amounts across the four categories. And we assumed that this in turn was also reflected in their login activity through single sign-on. Next slide, please. In addition, we used multiple physician specialty wage estimates from these different sources listed here, including the U.S. Department of Labor, Becker's Hospital Reviews, at that time 2015, Salary.com, Medscape Physician Compensation Reports. This yielded an hourly wage on average for hospitalists of $108, $144 for emergency medicine physicians, and about $170 for general surgeons. I would say that these estimates, if they err towards being conservative. In other words, in all likelihood, in many hospitals in the country, these different specialties probably earn more per hour, but we felt that we wanted to be on the conservative side so that all of the financial value of SSO we would show to our system leaders would be on the conservative side and would not at all have any risk of being seen as inflated. When we then averaged out the four categories of our physicians, we arrived at a generic physician average hourly rate of $138 per hour. Next slide, please. So what this slide shows you is the results of when you do the simple math. The simple math here is simply multiplying based on our stratification of the three different groups of SSO end users, multiplying their hours of liberated time from keyboard by what our estimated hourly wages for each of the three categories. And when you do that, you can see in the third column here from the left, or the second in from the right, that if you look at physicians, the annual value of liberated time from keyboard, the value financially of liberated time of those clinicians equaled about $106,000 per facility. When you multiply that across the 19 facilities in which we implemented single sign-on, it comes out to roughly over $2 million on an annual basis. For nurses, the similar numbers are about $50,000 annual value of time liberated from keyboard per year, and across the 19 facilities, over $960,000 per year. For ancillary, just shy of $11,000 liberated in time per facility per year, and across the 19 facilities, $205,000 per year. And when you sum up these figures, for an individual facility, it's over $168,000 of multidisciplinary clinician time freed from just tapping on a keyboard in order to do other work, presumably delivering clinical care to patients on an annualized basis per hospital. And across 19 hospitals, the value of that liberated clinician time is over $3.2 million per year. Next slide, please. We also tried to assess what our savings would be in terms of avoiding the purchase of replacement workstation PCs in favor of the ThinKline or WISE devices that replace those PCs. And again, as I mentioned earlier, there's a substantial $700 savings here per device. So it's not inconsequential. When you multiply that by the number of WISE devices we deployed across these 19 hospitals, which was over 2,400 devices, the savings over the next fiscal year at about $425,000 of averted PC purchases per year, over 8 years, we projected out that this will deliver a savings to the system. And now this is not liberated time, this is actual money returned to the budget of over $3.4 million over that 8-year period. Next slide, please. So we tried to then arrive at what is our net value when you look at factoring in what it cost us to implement SSO. Our enterprise total implementation cost was around $1.23 million. We estimated that the annual maintenance cost for single sign-on is just shy of $300,000 per year. So when you factor this in against the savings that we just talked about in the last table, and adjust for the equipment costs as well, the net total annual recurrent value or savings, if you will, from single sign-on is about $3.3 million over these 19 facilities. And as a result, I think it's clear that single sign-on really delivered substantial recurrent annual return on investment value and net cost savings to the Christus hospital system. Next slide, please. This table really just summarizes those key findings that I just articulated to you. The averted cost per year of PC purchases at $425, the clinician time added on top of that, and then the net value once we've factored in against that, the cost initially and ongoing for single sign-on implementation. Next slide, please. By the way, I want to mention for anyone who is looking at implementing single sign-on, this study was extremely easy to complete. The data is readily available to you from, I would imagine, most single sign-on vendors, and it's certainly available from Improvata's product, OneSign. And all of this analysis and this whole study, if I tell you that it took 20 to 25 hours to do the analysis, that would be on the high side. And then just the time to write it up, create the tables, create a report. So it's a very time-efficient study. And what we really liked about it from the point of view of the health informatics and the information management team is, and I'm sure many folks who are on the call have experienced this themselves. You know, every year you go through budget cycle, and always health IT is a big budget nut. And almost invariably, there's someone on the team who said, "Boy, we spend a lot of money in IT. Do we really have to be spending that much money?" And of course, you know, when you then say, "Well, what would you like to cut out of our essential information systems to save money on?" It's never possible to identify anything, because everything that our information technology delivers to the system is essential for the conduct of both clinical care and the business of healthcare. But we thought nonetheless, if we could really illustrate in this one instance the concrete quantitative value in reality from real data and real implementation, that it would be a very compelling, if you will, educational and awareness creation effort on our part to the rest of the colleagues on our leadership team beyond health IT. So if anyone is interested in doing a study like this themselves, on the last slide that I'll leave standing when we go to Q&A, I provide my email address, and I would be more than delighted to assist you in any way possible if you were interested in doing such a study in your own facility or system. So moving forward, in addition, we had other results. We didn't survey the clinicians in a systematic manner, but I used to round, as many members of our IT team rounded regularly in our facility. And we were able to observe extensive favorable reports from our clinicians. They praised the improved ease and speed of access to the clinical workstation and all their various applications. We also heard clinicians tell us that single sign-on facilitated their adoption of the EHR. As it turned out, our implementation of digital documentation, we did CPOE first and digital documentation subsequently. And our implementation of digital documentation overlapped with that of SSO. And a number of physicians reported to me personally that a single sign-on enabled their adoption, their more ready adoption of digital documentation, and made their use of CPOE much easier. Next slide, please. So the conclusions of this analysis and the data we've collected is that single sign-on had a significant favorable impact on clinician efficiency and productivity in these 19 hospitals. Because the time that's liberated, which as the slides have shown, were substantial time liberated, that time is not going to be going into something wasteful. It's going to go into patient care. It's going to go into clinicians thinking about their patients' problems, assessing their patients, and formulating the best possible care plans for their patients, as well as actually communicating with patients, engaging them and their family members, all of which we know contributes significantly, not just to treatment efficacy, but also to patient satisfaction with their hospital experience. So in our experience, single sign-on was an effective and highly cost-effective method to liberate clinician time from the repetitive and time-consuming logins to the EHR and clinical applications that existed prior to SSO implementation. And we feel that SSO can facilitate adoption of key component EHR functionalities and various other software applications that are integral to diverse clinicians' clinical workflows. Next slide, please. Again, our lesson in this was that any facility or system may need to update or upgrade other components of their IT infrastructure in order to get SSO implemented well and functioning robustly and achieving its potential value. And in our instance, that involved replacing the PCs with thin clients and enabling cloud processing and a virtual desk environment. This reduced, as I mentioned, our need for costly PC replacement and upgrades and produced substantial hardware expenditure savings. And as I mentioned, a single sign-on has been what we consider to be a strong clinician satisfier with clinicians reporting that it enabled them to focus more attention on patient care than dealing with the IT that has become so integral to clinical care delivery today. Next slide, please. So while single sign-on is not game-changing in the sense that it has a dramatic and overwhelming impact on the amount of time that IT demands of our clinicians, we feel that it provides an incremental, real, and meaningful liberation of clinician time and an improvement in clinical workflow. We recommend, on the basis of our experience, then, that SSO implementation be considered in hospitals where multidisciplinary clinician use of EHRs and related technology is substantial, and where clinical workflow involves substantial facility roaming. Next slide, please. And finally, we feel that SSO can save time, improve security through improved authentication, and increase clinician productivity and satisfaction in today's very complex healthcare organizational workflows. So with that, I'm happy to answer any questions that you might have. Thank you very much for your attention. And here you see again my email. And again, if anyone is interested in conducting some such similar evaluation of the value of the implementation of single sign-on in their own facility or system, I'd be more than happy to provide any advice and learnings from our experience in doing the same thing. With that, I'll turn it back to our moderators to see if we have any questions.
Thank you so much, Dr. Gellert, for that fantastic presentation. We will now begin today's question and answer session. You can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We already have a few great questions that are coming in. So Dr. Gellert, one question that we have coming in here from an audience member is, how has single sign-on impacted the user, and what kind of feedback did the users provide?
Well, as I hope the data conveyed, from the point of view of clinical end users, single sign-on saved them time. It saved them time from the very mundane and, really not technical process of logging in. And, if you only log in once a day in your particular role, you don't appreciate what our clinicians are going through, because they don't just log in once a day if they don't have single sign-on. They're logging in on and on and on all day to different software applications. They're being auto-logged off due to, HIPAA security requirements. And it's an area that is a pain point for our clinicians in their workflow. There's a lot of things challenging our clinicians these days. We know that. The introduction of evidence-based medicine, the shift from volume to value-based reimbursement, a lot of this is falling onto the responsibility of our diverse multidisciplinary clinical teams. And so the reason CHRISTUS went into single sign-on, frankly, initially was not that we anticipated any ROI like demonstrated in this study. We really didn't. And before we implemented, we had no idea whether we could even demonstrate an ROI. We really wanted to do it because, part of our core messaging to our clinicians is that there are partners in EHR adoption, and as we move into a fully electronic system that is evidence-based, and they bear the brunt of that in terms of additional consumption of time in their daily workflows. And so the reason I think that the CHRISTUS leadership team decided to invest in SSO was really to do something that was, relatively speaking, quick and easy, to help our clinicians and reduce the time that they're wasting on login, because that's truly wasted time. There's no clinical value delivered by typing your login credentials to a keyboard. And so it was a goodwill gesture, really, for us to, if you will, kind of walk our talk and show that we don't just rhetorically support our clinicians. Where we can make investments to make their lives easier in terms of using the EHR, we do so. So as you can see from the data, the impact was across a broad cut of our clinical team, physicians, nurses, ancillary. We provided it subsequently to other folks as well, to administrative staff and so forth, insofar as we had additional available licenses to do so. And everyone who has gotten it really felt very positive about it. So much so, frankly, that we've never had a really significant downtime. The system performs at, something like a 99.89 or 9-something% uptime. But it's the kind of thing that we know if we took it away tomorrow for some reason, or if it didn't work tomorrow, everyone would be pretty enraged. So it's a pretty popular thing to do for your clinicians. And again, as the data showed, and again, we didn't know this going in ourselves, but the data, I think, really justifies that not only is this a good thing to do for your clinicians to make them happier and make their work lives a little easier, the implementation essentially more than pays for itself in terms of the value of the time that you're liberating your clinicians from typing on a keyboard and instead to deliver high-quality care to your patients. I hope that answers the question.
It does. That's great to hear, the positive feedback from the clinicians, and then also some of those unexpected benefits that y'all received, and a little bit more about the Christus story. So thank you for sharing that. Perhaps, you can dive in a little bit more into if there were any barriers, either unexpected or expected, that you came across.
There were two. So the first was, as I mentioned in the presentation, when we did a pilot, we picked a hospital and that was a very tight community hospital, a very tight organizational culture, and they were very open to being our guinea pig, if you will, for a single sign-on. And at that time, we were trying to operate on the basis of our existing infrastructure with the desktop workstations as the primary focus of computing. And that was a pretty dismal failure. The single sign-on just didn't perform as it should have. It performed partially. But, if you're a cardiothoracic surgeon and you're accessing, 15 different apps a day, and single sign-on works great for 12, but then doesn't work for 3. And, you're not sure, do I log in then the traditional way, or, this is the kind of thing that it has to work perfectly almost every time, if not every time, and be very seamless in terms of integration into the clinician's workflow. And so it took our team some time to, if you will, determine the etiology of our problems. With our pilot implementation. And I'll be very frank with you, the clinical and administrative leadership team and all the clinicians at that facility suffered, and they probably suffered, longer than any of us would have desired. But they helped us figure out the problem. And when we migrated to a VDI and cloud-based solution, and we replaced the PC workstations with the thin clients, the system worked like a dream. We never had problems again, and all of our end users were very satisfied with it. So it was a painful learning, and that's why I share with anyone considering implementing SSO to take a very hard look at your infrastructure, your existing IT infrastructure, and ask yourself and demand from your vendor where they think there may be weak points and what other areas of your infrastructure you may need to upgrade in order to deliver really perfect, seamless SSO performance. The other little complexity that we faced was, and this is not necessarily even related to SSO per se, but anytime you have a go live that affects systems more broadly, and in particular affects access, anytime there's any problem in the system, any issue, it could be with your access to the internet or any area functionality of the EHR or some other application or the supportive infrastructure. any problem would be by the end users during our go-live period in each of the hospitals, immediately faulting and blaming the problem on single sign-on. Because that's what was visible and that was what was changing. So it's very understandable from a human point of view that our end users would often, if you will, misidentify the origin of a unrelated problem to a single sign-on, but assign or attribute fault to the single sign-on implementation. And I think that's inevitable to some extent with any go-live in informatics. And the only way to really deal with it is by getting to the source of those problems and educating end users that, in fact, it wasn't SSO, it was X or Y. That was the origin of this particular problem, and we've now corrected it, so you should have no further problems. So I think that's pretty routine. But those were really the only two problems we had. I guess you could add in there possibly that because it's such a satisfying end user experience once you've got SSO working right, you need to be ready for somewhat of a and I use the term really with humorous intent. You need to be ready for the assault of pretty much everyone else in the hospital who roams and who has to log in a lot. And as I mentioned, our original plan was just to go with the physicians and the nurse end users and enable them to have SSO and get them licenses. But once the ancillary saw what it was doing, how it was transforming the workflow of those clinicians, they naturally wanted it themselves, and they, appealed quite passionately that they should be included in the go live, and we were happy to accommodate that. But you need to be ready for that, and if you're planning on doing something less than the total set of clinicians who roam the hospital and are logging in frequently and would benefit from SSO, you need to anticipate that those not included in your original plan may end up coming to you and demanding that they be included fairly soon in a subsequent phase of your implementation. Beyond that, we really didn't have any major problems, and really those three.
Wonderful. Well, thank you for sharing a little bit about some of the roadblocks you encounter and what sounds like some great lessons learned. You touched on this in your last answer here, but were there, one or two things that you would have had done different at all in your facilities?
Well, I think if we were to do it all over again, obviously we would immediately go to a virtual desktop and cloud-based with a thin client for our implementation. But that was a lesson we needed to learn by hard discovery. And once we learned the lesson, we move forward with it. And the other one is, just as I mentioned, really anticipate the potential popularity of this. And if you're going to be very restrictive about your distribution of licenses and access through SSO, you need to be prepared for some political fallout in your organization, because folks don't like to hear that while they would benefit from an application very clearly, that they're not going to be able to because of whatever reason, budget or a desire to have a serial or phased in implementation. So my recommendation would be to avoid that up front is, first of all, canvass different specialties, different members of the care team before your go-live planning or as part of your go-live planning, and either anticipate the need to get enough licenses in your budget or develop a phased-in strategy that, over X quarters or over a subsequent fiscal year, that budget will be there to support the eventual engaging of all desired clinicians with SSO.
Fantastic. Thank you so much. We have a question here, more of a technical question. Will SSO work with mobile devices? And we can confirm that yes, SSO will work with mobile devices. If you're referring also to being able to access multiple applications on a mobile device without logging in multiple times, the answer is yes there. So wanted to address that quick technical question before we jump into the next question for you, Dr. Gellert. We have an audience member that is asking if you can discuss further the cost aspects of implementing this into your organization.
Well, I don't know if you want to try to go back to that slide, but what we basically did to determine what the cost basis was literally go back through our budgets, and the budget owners told us exactly what we had paid our vendor, Imprivata, for our implementation, and factoring into that, of course, the number of total licenses that we purchased. And then we annualized that moving forward. So there are obviously initial costs that occur and that are effectively one-time costs, and then there's the annual subscription, if you will, to the licenses. That is a recurrent cost. There were other expenses that occurred and other investments that occurred in our IT infrastructure over the years, the last 3-year period in which from when we first started the very early implementation of pilot through to completing these 19 hospitals. But if that infrastructure investment subserved another area of functionality primarily, though it may have had as well a benefit on single sign-on, we did not factor that in as primarily a cost of single sign-on. So the costs I presented to you are really the SSO specific initial implementation costs, and then the ongoing costs. One thing I should also mention that I failed to during the presentation is that we did this study actually in different phases. We did our first analysis after implementing just 6 hospitals. And at that time, the re-login time was considerably higher than what we ultimately achieved. And over time, due to a number of other changes and improvements in our IT infrastructure, there was a direct benefit on both the initial login time, as I've shown you earlier in the presentation, and a really dramatic reduction, even from the first 6 hospitals, in the re-login time. And I've queried my IT colleagues many times, because inevitably there's someone in the audience who asks, so what did you do exactly to get such a dramatic reduction in the re-login time? Because that's really where we see the yield in terms of overall time liberated from keyboard and the financial value of that liberated time. And the response I've gotten invariably is that there were too many changes to really enable any sort of real attribution. The routine kinds of upgrades and improvements that I think any hospital IT system pursues over time. But it is worth noting that we saw between the 2 study periods, the first 6 hospitals that after the first year of implementation, and then all 19 hospitals implemented thus far a few years later, this dramatic reduction in the re-login time and then the value as a result of our ROI from SSO. And I would go further to say that John Crouch, who really leads the team to drive these improvements, not just in single sign-on, but across our IT infrastructure at Christus Health, did so during the period I was there and continues in that role. He just mentioned to me a few weeks ago that they've been doing some improvements and they're seeing even further reductions in the re-login time than what we've reported in this presentation and will appear in Perspectives of Health Information Management in July in the journal. So the point I wish to convey by mentioning all of that is that this is dynamic, and the value you get may increase over time as you continue to advance other elements and components of your IT functionality and backbone. And we've observed that, and it's ongoing. Frankly, after I got this second round of data that we talked about today in the presentation, I really wondered if there was really much more room to squeeze out time. And so I was very surprised and delighted to hear from John that he's continuing to see improvements in that regard. And if they're really dramatic, frankly, we'll probably do yet another analysis maybe a year from now and see what the numbers look like at that time again.
Fantastic. Thank you so much, Dr. Gellert. And it looks like we have time for one last question today. And could you talk a little bit about the impact of SSO on cybersecurity?
It improved it. Improvata's SSO product, I can't speak to the entire, the entire market, but our experience with our vendor was that this added additional layer of authentication and did so in a very unintrusive manner from the point of view of the end user. And so we feel that implementing single sign-on only improved our health IT security. And we have, a designated team leader, a chief information security officer, Christus has a chief information security officer, fully dedicated to nothing but ensuring and advancing the system's IT security and integrity. And we had no issues at any point with regard to any introduced vulnerabilities. And as I say, quite the opposite. We feel that the system is even more impenetrable now with single sign-on implemented than it was previously. And so we think it's a net advance in our IT security and our HIPAA compliance.
That's fantastic. Wonderful. Well, Dr. Gellert, I want to thank you so much for your wonderful presentation today and for Improvata for sponsoring today's webinar. We will look forward to having you join us for future webinars. Thank you.